GATT surgery, gonioscopic assisted transluminal goniotomy, is a game changer in the management of pediatric glaucomas. Besides being blebless, it does away with all the side effects of the bleb. However, pediatric GATT is fraught with many difficulties when compared with GATT in children. The foremost thing is to identify which patients are the most suitable for this surgery. For example, in this picture, we can see that the left baby, the cornea are opaque and therefore he is not a good candidate for the GATT surgery, while the right baby is little older than 2 years and therefore again, although the cornea is clear in the right eye, GATT surgery may not give optimal IOP lowering effect. And therefore, it is a suitable surgery for children in first 2 years of life with clear cornea or in those patients with failed trab. The foremost prerequisite for performing GATT surgery is identification of the correct site for Schlemm's canal cannulation in these patients. However, the pediatric glaucoma patients, they are a difficult group compared to adult group because they have inherent problems in trabecular meshwork identification. They may have hazy corneas because of the corneal edema or Harp's trial. The trabecular meshwork is also poorly pigmented. There is lesser blood reflux into the trabecular meshwork. The uveal meshwork is also translucent in some babies, giving less contrast. The iris may be highly inserted and therefore obscuring the trabecular meshwork and not being able to identify the trabecular meshwork in most patients. They also have greatly stretched eyes, causing alteration of the infantile anatomy, and the correct location may not be clearly evident. There may also be a presence of primordial membrane over TM, further reducing the contrast. Therefore, it is important that we identify the Schlemm's canal correctly. Before we go on to performing the GATT surgery in children, it is imperative that we correctly position the head of the baby. For example, in this patient, if we are to do the right eye of the baby, the head is to be shifted towards the opposite side so that the nasal angle of the right eye is exposed. The microscope is also tilted down to enable maximum visualization of the nasal angle. And then Swan-Jacob lens is used to enable visualization of the nasal angle. So before we clean drape the child, it's important with the help of anesthetist, we tilt the head of the patient and also tilt the microscope for best visualization of the angle. So because of poor contrast, we have described that blood can be made to reflux in these eyes and help us in identifying the Schlemm's canal by external jugular vein compression. So as we compress the external jugular vein, it causes blood reflux and a bright red streak of blood is visible, and the incision has to be made at the anterior most border of this red line, which gives us optimal results for the GATT surgery, and cannulation is successful. This paper is published in Journal of Glaucoma. Also, similarly, ICG dye can be used to help us assist identification of the Schlemm's canal in these patients. ICG stains the trabecular meshwork, and again at the anterior border of the stained trabecular meshwork, the incision has to be made. If we make the incision at the right place, cannulation is successful. This is also published in Journal of Glaucoma and can be read carefully in this. Trendelenburg position in children also help in the same thing of blood refluxing, but sometimes it may not be feasible in GA conditions. Trypan blue may also be used for identification trabecular meshwork. However, since it is darkly colored and iris is also darkly colored, the contrast imparted is poorer compared to ICG dye or the blood reflux. Sometimes when we are cannulating the Schlemm's canal, we are not very sure that the suture is going in the right direction, unlike with the LED tipped microcatheter where we know that the LED light is going in the right direction. So in these cases, whenever we are in doubt of suture misdirection, we can use IOCT if it is available, and it gives us an inverted angstrom sign where there is a dot at the apex of the A, which indicates that the suture is right there, and this can help us be thorough and confident about the position of the suture. Up the child for GATT surgery, it's important that we know that the Schlemm's canal is adequately formed, and any surgery of the angle will give us good results. In these cases, we also can perform ICG angiography before deciding for patients to be taken up for the angle surgery. In this, the flex module of the spectralis Heidelberg is used for ICG angiography. ICG dye is instilled intracamerally into the eye of the patient, and ICG mode is switched on. As the dye flows through the aqueous channels are highlighted, the dye being fluorescent. So this we see that the Hauptstria are well lined within the cornea, and as the dye is flowing out of the eye, the distal aqueous channels and the Schlemm's canal can be appreciated. So these children with well-formed distal aqueous channels, they are good candidates for angle surgery, unlike those where the aqueous channels are not seen. Post-operatively, after we have done an incision through the GATT surgery, the clefts are well identified on the ASOCT or the IOCT. And this further helps us to confirm that the positioning was correct. So this is a video demonstration of how we can identify the Schlemm's canal and how the surgery is completed when we know that we are in the right space. So this is a case of primary congenital glaucoma, 3 months old baby with a unilateral glaucoma. And under Swan-Jacob gonioprism, the nasal angle is identified. A goniotomy limited is made at the anteriormost border of the trabecular meshwork with an MVR blade. It gives us a good white reflex of the underlying sclera or the outer border of the Schlemm's canal. And then through the infranasal port, a 6-0 Prolene suture with the tip bent, rounded with a high dose cautery. The suture is held with an SF5L forceps which is bent, and then it is advanced through the Schlemm's canal through this goniotomy. We can see that the trabecular meshwork is so lightly hued that the advancing of the suture through this trabecular meshwork is well visualized. It is progressing in a parallel direction to that of the iris and leaving little doubt that it is in the right plane. When we see from the opposite end the other part of the suture coming out, this is the end point. There is minimal resistance as the suture is going. This also helps us to confirm that we are in the right plane. So we hold the other end of the suture that has come out through the opposite end with an SF5L forceps. And taking the prism off, we hold the external part of the suture with the McPherson and rip apart the trabecular meshwork through the circumferential location. The suture is then pulled out and the viscoelastic is aspirated using bimanual IA. Since GATT surgery can cause bleeding by refluxing of the blood through the Schlemm's canal, it's important that we close the eye under high pressure using air. Sometimes when the bleeding is not stopping, we can also leave some amount of cohesive viscoelastic in the eye. It's important that we suture the ports at the end. Pilocarpine postoperatively can help in reducing the incidence of pus formation at the raw surface of the Schlemm's canal. And if in case hyphema persists at 1 week, it may be required that a hyphema drainage is performed under GA. So to summarize, GATT surgery is less invasive, reduces the need for medications, is blebless and is mostly free from complications, doesn't hinder with the post-operative visual outcomes, no intensive post-operative care is required, EUAs are less frequently required, IOP lowering is consistent as we have seen for maximum 1 year till now, and conjunctiva as well as sclera, they are preserved for future filtering surgery even if the need arises. So in all, a win-win situation for both the pediatric surgeon and the child as well as the parents. Thank you very much for patience.